tuberculosis, because none responsive to a previous treatment had received the triple therapy, and you saw the result. It's very, very interesting because it's different from the pilot essay, and this is the real life. And we observed in this study that the tolerance of the drug was not so good, at least in this patient, cirrhosis. And we are waiting for the. And we had a sort of evaluation of this patient in the context of biochemical research independent of industry. It's very, very, very important. And the last study in progress is the evaluation of the cost effectiveness for universal, why not, HCV testing in relation to advance in therapy, to tomorrow, probably 90% of 100% of them could be cured with new therapy, especially without interference. There is no life today without evaluation. And this evaluation of the present master plan was planned before the implementation, and this is in progress. It's an independent committee of the strategic committee in charge of the plan. It's very important. And this was proposed by the National Council of Public Health. And of course, we are waiting with great interest the advice and recommendations of the committee the December this year. And of course, it will be very useful for preparing future master plans because we can postulate that hepatitis will remain a major problem of public health in the future before the disappearance of this virus in 20, 30 years. Thank you.
Thank you, Daniel. And now we have two presentations. Achim mentioned this from Bulgaria, which I think is very important. And we are very proud that also the Deputy Minister of Health from Bulgaria will be here. And you will start? Yeah, wonderful. So it's Mrs. Dimitrova from Bulgaria, the Deputy Minister of Health. Thank you.
Thank you. First of all, I'd like to thank the organizers for inviting Bulgaria to this meeting. It's a great pleasure to be in the company of such developed European countries as France and Scotland, and I'm proud to share about Bulgaria's plan. I plan to speak about first the context in which Bulgaria developed that action plan, and then a little bit about the plan, just the policy and the rationale behind it, and finish with next steps. And after the first two presentations, I've come to realize that actually the next steps are a lot more than I actually had thought before I came here, especially in terms of making it really data-driven, because that is what will ensure, on the one hand, sustainable financing, and on the other hand, better patient outcomes. So these are the topics I will be sharing. Context, national plan, and then next steps. So on the context, the policy focus of the Ministry of Health has really been on disease prevention. We recently developed and have been developing a national strategic framework for 2013 to 2020. And our main focus will be on preventing both communicable and non-communicable diseases. Treatment, of course, will continue to invest in that, but we would like to increase the investment in prevention. We've based that on the European Health Strategy Health 2020 of the World Health Organization, Bulgaria has the honor to be one of the countries that is on the governing body of the World Health Organization for Europe, the Standing Committee. And we've really been very active in ensuring that the World Health Organization for Europe's strategic plan includes disease prevention. And really the balance on non-communicable diseases have been increasing, so a lot of focus has been placed there. But for countries, post-communist countries, where immunization programs have sort of fallen through the cracks, focusing and continuing to focus on communicable diseases is really essential. So in the European Health Strategy, Health 2020 of the World Health Organization, we've really worked hard on including as a priority communicable diseases along with non-communicable diseases. And of course, Together for Health, the EU strategic approach for 2008-2013 also focuses on disease prevention. The enabling factors for us to focus on disease prevention have really been the financial crisis. It might be counterintuitive that in a moment of decreased financing, we actually decided to invest in prevention. But really, the initial impetus was we were asked by the Ministry of Finance to cut costs, even though at the end of the day we managed to increase our budget by 2%, and we've, all through the financial crisis, have had higher expenditure rates than the previous year. But we were asked to look through all of our programs and see ways in which we can optimize our expenditure. So the first thing we saw was that there was a lot of redundancy in our national programs, especially in programs on related to non-communicable diseases such as tobacco, nutrition, physical activity. It was actually shocking to even see copy and paste from one program into the other one because the interventions are similar. And then we had started developing a program on cancer, on diabetes, but the risk factors are pretty much the same. So figuring out a way to integrate all of our disease programs and the risk factors into one actually made us reflect a little more on what outcomes we're trying to achieve and what interventions we can take that can build on each other, and we can use economies of scale of some sort. And then we looked at our expenditures at the Health Insurance Fund. That was something everybody knew, that we actually spent way too much on disease treatment and not so much on prevention. And here I'll just share one little graph. On the very right is the percentage, our expenditure as per the categories of expenses of the National Health Insurance Fund. It looks like the data has a little bit, the markings are not very orderly, but you get the point. On the bottom is our investment in inpatient services, outpatient drugs, and medical devices. And we spend about 47, almost half of our expenditure is on treatment. And the comparison in other EU countries is about 30%. So we went around talking about this data, and it's actually very difficult politically to invest in prevention because you have 5 million, you give it to a hospital, they get excited, go in the media, give a nice interview about the government and about the investment the government makes. But when you invest in prevention, the effect is probably going to be 2 governments down the line. Nobody would go back and say, you know, that was because of the national hepatitis plan that government three parties ago had developed. So politically, it's a difficult thing to do. But we thought we would do it because of and we really looked at the financial crisis as an opportunity. This is just some quick data on treatment of hepatitis, and this is for chronic hepatitis and for acute viral hepatitis just in the last 4 years that we looked at. This actually excludes the treatment for cirrhosis and liver cancer. But we see increases of 480, 360%. So the only way to really tame this huge growth is by focusing on prevention. So once we looked at the data, the political message became a little bit easier to say, you know, this is not good for the people. It's really, it might be nice politically to be able to get a few hospital directors to speak about the greatness of the government, but really for the people it's not good to continue that way. We really have to make a turn and reorganize and rethink our approach. Just one thing is that we've actually had recently quite a few screening programs. So this curve is that sharp because of the screening, but in any case, it's not natural to have such huge increase in treatment costs. So just to go back a little more on the context, increase of the burden of disease in non-communicable diseases has really been our focus and the focus of Europe in general. We see reduction in overall communicable diseases, but still Bulgaria has one of the highest communicable disease rates in the EU and very frequent outbreaks. So that makes us look at all of our expenditures for prevention. And the actions we took was first we developed a national program for prevention of non-communicable diseases, and that was in the context of looking at the already existing programs for nutrition, physical activity, alcohol, and tobacco, and realizing that we can actually merge them into one program together with a program on diabetes, cancer, pulmonary disease, and this gives me the first one. Kind of merging all of our risk factors together with the main non-communicable diseases. And then we started looking at the communicable diseases, and the hepatitis program was one of the first ones that we started to develop. And now I will share a little bit about the rationale of why we started with that one. The first reason is that prevention is actually proven that it's effective. Bulgaria was one of the first countries to introduce the hepatitis B vaccine in 1991, and I'd like to take the opportunity to congratulate the government that was leading Bulgaria at that time for making that decision, because now we have 10 times lower rates than at the time when that vaccine was introduced. So we'll be thinking about introducing that for hepatitis A. And then it's clear, as in all diseases, that early detection leads to avoidable hospitalizations. There is no costing of that yet, but we'll be looking at the more advanced countries like Scotland and France to figure out ways to collect our data and organize that, because that would be a message that we can bring into the Ministry of Finance. We found that speaking their language actually is what has increased our budget. If we can prove to them that the funding that we have will be used in a way that would bring about reduction in future expenditure, actually helps in the present moment. The second reason we focused on developing this program is because the burden of disease is too high. I won't go through all the figures. You already heard quite a little bit about it. Just to illustrate that we've had a few screening programs that have been funded. There were public-private partnerships that have led to an increase in the number of patients because we're actually identifying. So we're being very conscious of the fact that we're not pressing the number of patients down. We want to identify them as early as possible. And the third reason is actually that we had a very successful partnership with a non-governmental organization that deals with this work. With Stanimir, we work very well, and I think from a government's perspective, having civil society take a lead and encourage the government actually really helps. So that's a good practice that other countries that are thinking of developing such a program could take. So those were the three reasons we went about developing this national program. In terms of the content, we want to focus on prevention, on figuring out how the screening would be done, who the target groups would be, what the early detection would be. There won't be a focus on treatment, and what I've observed in both the development of the program on non-communicable diseases and this one is that there's always, the experts are always saying, let's go into the treatment as well. I think it's, I'm a health economist, I'm not a doctor. I think in the doctor's blood there must be something that is always going for the treatment, but we've really been very strong about the fact that we are focusing on only prevention with this national program. And then the process has been really to bring about as many actors as possible. I was very struck by Margaret Chan at the Regional Committee of Europe this fall. She said, you know, Ministers of Health, your job description has really changed in the past couple of years. Your job is not really to look at the health system, your job is to coordinate among all the actors in the health system. We now have data that only 10% of health outcomes are due to the strength of the health system. All the other 90% are because of other factors such as the environment, such as the nutrition, behaviors, etc. So for us in developing this program, we really wanted to bring about stakeholders not only from the health sector but from other ministries, also national consultants, researchers, non-governmental organizations. And then the next point is about finance, and that's always the hardest part. A small part would be financed, we envision would be financed from the Ministry of Health. And again, to make a commitment to finance this program now was not easy. And as a first step, we looked at the fact that we're already investing in hepatitis prevention with a vaccine. So a first step is just organizing all the interventions that we're already making and placing all the investment that is already there into the budget, because money is already being spent. It's just a different way of organizing and tracking the expenditures. Then additionally, we're looking for the second vaccine at the National Health Insurance Fund. In Bulgaria, it's different. It's a little bit atypical. Vaccines are financed by the Health Insurance Fund, not by the Ministry of Health. So that's something that the Health Insurance Fund can finance. And then EU programs as well will be looking into as potential sources of funding. And we're really following, in this case, the same way we finance the national program on non-communicable diseases, figuring out all the ways in which we have a little bit of funding and scaling it up and organizing it into the right intervention. And we'll also be really looking into public-private partnerships and continuing on the way the screening has been done through public-private partnerships. We think that it's important to make the commitment to have the program, figure out who the right people are to be involved, and move along with the process, and then find the little pieces of the puzzle in terms of the financing. My observation and advice for the countries is not to shy away from going with the development just because the funding, all of the funding is not there up front. We just need to define what the interventions are, and then when they're data-driven, and it's clear what the impact of them would be, the funding can come from private sources, from donors, from EU programs, etc. I think the harder part is to actually figure out what are the right steps for the particular country. In terms of next steps, so it's the completion of the technical content. We're going to have a very big public discussion and securing of the financing. That I feel that once it's well written, the securing of the financing is not going to be a problem. An approval by the Council of Ministers, that's the normal legal path that countries go through, and then implementation. And now I'd like to turn to Stanimir, who will be Dr. Hasarjeev for the official part of the meeting, who will share a little more about the contents of the program as he sees it, and as he has been very involved in the development of the program, as well as the timeline that we'll be following and the process that we'll be going through. Thank you.
Thank you very much. I'm actually very much pleased to be here today and proud because I'm also executive director of the European Legal Patients Association, but at the same time I'm proud that my country, being one of the poorest in Europe, is actually taking some actions on that. I'll try to be really brief, just to give you some technical details about how we are planning and the timeline and everything in our national hepatitis plan. But actually, as you probably can see, this plan is a result of really great collaboration between the non-government sector and our government. I'm happy that we have so open government, and it played a key role that they trusted us, that we need this plan, they trusted our experts, and I know how challenging this could be for a government of a country with low GDP to make a commitment that they're starting to do something on hepatitis in terms of financing a national plan or whatever. But at the same time, I'm really happy that they committed on that, and I'm sure the financing will come properly with that, with proper data, and we'll find a way with our national plan. So, luckily in our country we have a legal framework for development of national health programs, and this legal framework is stated in our health law. At the end of the day, a national program is adopted by the Council of Ministers, which makes actually the national programs to be strong documents that go together with their financing, and usually they're implemented by the Ministry of Health and proper people dedicated to every separate program. So the programs are developed based on the assessment of the health condition of the certain condition, health needs of the citizens, demographic trends, resource and capacity of the healthcare system. It's good that we have a good guidance from the World Health Organization and their framework for global action on hepatitis and prevention and control of viral hepatitis infection. And we will try actually in our plan to make sure that we have the 4 axes, the 4 major topics stated by WHO as being important for the member states. So these are some of the elements that we are planning to have in the Bulgarian hepatitis plan. Of course, the aims, the target groups, the activities, the time framework and all that. But what I think will be extremely essential for the future and for the financing of the program in the future will be actually to have proper mechanisms to monitor the program, to evaluate the effectiveness of the program, and to find a way to make it as sustainable as possible in the future. So what we have done up to now, a few months ago our government made a very strong commitment. We had a roundtable in our parliament together with all relevant stakeholders to start the development of the program, and following this roundtable an expert group was formed under the Minister of Health, and Deputy Minister Dimitrova is actually the relevant person responsible directly for the development of the National Hepatitis Plan. So we tried to have a multidisciplinary and multi-stakeholder group of experts. You can see here public health experts, epidemiology experts, infectious disease specialists, gastroenterology, but what is really interesting, and I think it's very important for us, is to have also the financial experts within this working group. And of course the patient representativeness, but I definitely think that pharmaceutical insurance experts and also the pharmaceutical industry could play a role, especially when we have such challenging times in terms of financing the new treatments and the treatments that we're expecting in the near future. How the things will happen? Just briefly, the Minister of Health creates this group of experts to start working on the program that has to prepare a draft. So we are in this first phase right now. After the draft is ready, it goes to relevant directorates within the ministry to have their statement. Then the management of Ministry of Health has to take a decision and to adopt the plan. After that's ready, the plan is put for public discussion for 2 weeks. This is according to the Bulgarian law. For these 2 weeks, everyone can make any comments on the plan. After this period, the plan goes for coordination between different ministries. All ministries in the country have to approve the plan before it goes to the Council of Ministers. So at the end of the day, the plan will go to the Council of Ministers for consideration and adoption. So it's quite long administrative procedure, but at the same time, it actually could take up to 5 to 6 months in order to finalize all this procedure, but I'm pretty much concerned that the procedure will be finalized. So the framework, actually the group is for, but we expect the plan to be ready and adopted until the summer of 2013. Thank you very much.
So thank you very much and congratulations to your efforts in Bulgaria. This is really impressive. Maybe, I think we have 10 minutes for discussion brief. I think we should take this time. So I would like to ask the speakers, have a seat here at the podium. And you should sit here. Okay, are there questions? This was quite some information. You have different experiences from different countries, and certainly we need to learn from other experiences, even though there are country-specific issues which we have to discuss. There was one comment and one question. Let's start there.
Well, congratulations for these important presentations we had from 3 different countries. Representing a global patient organization, I'm rather worried and concerned, however, on the focus on prevention. And I'm referring to the Bulgarian, which of course I need to congratulate because it is a real very good start and very important in any plan. But at the same time, there are many patients that need treatment, and prevention won't do much to the treatment of patients and to the consequence on their health and survival. So I would like to know what is being done or what will be done, and not only in Bulgaria, but in many countries that are focusing on prevention, and their budget is on prevention.
And then certainly I have to admit, doctor, we have different levels of prevention.
Yes, I understand.
And certainly treatment is preventing.
Well, yes, this is what I was going to ask. I'm a doctor myself, and I wanted to ask, because it wasn't shown the levels of prevention.
So what are the answers?
Thank you.
Bulgaria?
Just wanted to know.
Struck by Dr. Dylan's words, treat to prevent, and that's our approach. It's not that we have said now we're only going to prevent and then all the treatment stops. Maybe I should have clarified a little bit about how the Bulgarian health system is structured. We have the health insurance fund that finances all treatment in the country. So treatment continues. However, in parallel, of course, every Bulgarian citizen is health insured, and as health insured, he has the right to treatment. But in addition to that, we're focusing on prevention as well, and adding and investing in prevention. So it's not one for the other. I also mentioned that we managed to increase our health funding in the moment of the financial crisis. It's just that the increment we've invested in prevention, not only of communicable, but of non-communicable diseases as well. And one other point is that while in other European countries, treatment costs are about 37 to 40 of the cost of the health system, in Bulgaria that's 50%. So we believe that our health system's specific needs are such that they call for a concerted effort on prevention. But again, the treatment is treat to prevent. Thanks for your question.
Yeah, if you allow me to add on that, actually, the health insurance fund has the responsibility for the treatment. Luckily, our patients now are being treated. We're expecting the new treatments to come available in the country. But what we have discussed within the expert group and the panel, we will try to provide kind of framework for treatment, to provide possibilities for proper guidelines and for the experts to do their job. But the responsibility for treatment itself is usually not to the Ministry of Health, but to the insurance system.
Other question? Comment?
You can't do anything without political will. And I congratulate also all these presentations, which were very beautiful, very interesting. However, I did not really notice, I didn't, grip anything about integrating the new treatments that are coming. I heard you, mention them. And we know that they're going to be very expensive. And we have one concern in France is that we have people now on telaprevir and boceprevir, and we know you quoted Cupic. We know that they're not very easy to take, and we might have better drugs in terms of tolerance of safety later, maybe end of next year. And I didn't see in any of those presentations how you're going to manage with that, the cost issue, especially at the moment with the economic crisis.
So Daniel, you may comment on that one, but I think this is different levels from our perspective. First of all, it's very important that, for example, you in France have the opportunity of these early access programs. This is a big advantage as compared to other countries. For us in Germany, it was not possible. We've been able to use these drugs 9 months later or 10 months later than in France. The cost issue is certainly absolutely crucial, is important. But it's what I like in all presentations, the key basis for any discussion about cost is data. And we first have to generate really the data about effectiveness. Cupic is very important because we also learn that the new drugs, at least at this stage, are not the best for every patient. And this is what we also learned as doctors. Times will change so rapidly in the next 18 months that we have to repeat these meetings, in my view, very frequently, that we really know what the data is. And for us, for the societies, it will be extremely important to have extremely updated guidelines. Guidelines are outdated the day they are published. And this is our problem. And therefore, EASL has also developed a more flexible tool, not to have a consensus conference which takes ages to get the new data out. We need to have a recommendation on a very high level by experts as soon as the new drugs are available. This is our responsibility, and the societies are working on that one. Comments from France and Scotland. How do you deal with in Scotland with the enormous chances, but also cost issues of the new paradigm?
We are starting to plan in Scotland as to the new drugs. The problem is we're planning in a vacuum. Not only do we yet know which drugs are going to happen, what are the drug companies going to charge? To try and be proactive, we're looking at repeating the modelling work I showed you before, looking at different costs of drug. I think every country has a ceiling on which it can spend money, and it can't go above that. And that's the reality, whether we're in recession or not. There's a finite limit where the money goes to other things. So we have a relatively fixed amount of money to spend on the drugs. And I think we need to open up a conversation with the drug companies. There is this limit. Price your drugs so we can cure more patients within that budget, and don't price us outright. And I think in that situation we then have to look, while I accept the existing drugs are not easy for patients to take, I think we need to open up the conversation. If your drug is too stupidly expensive for us, it is better for us to use these. We need to have that conversation with organisations. As to Charles is smiling at me, we've had this discussion before, as to how if it means your chance of cure is the same, but with the old drugs it takes 6 months, the new drugs it takes 12 weeks, but it's 5 times more expensive with the new drugs. How do we square that argument? Do we treat 5 times more patients, or do we treat one patient for 12 weeks and spare them 12 weeks of therapy, and another 4 patients who don't get treatment at all? And those hard discussions, and that's where patient organisations have much more power than shroud-waving clinicians. Governments are very good at pushing shroud-waving clinicians away. They don't like pushing away voters. For some reason, they don't think doctors vote. I don't know.
So brief comment from Daniel on that issue.
The question of our present Minister of Health is it's an enormous cost.
That's why I was asking. That's why I was asking.
But cirrhosis is severe and costly. Hepatocarcinoma is severe and costly. Liver transplantation is costly. And we have now treatment with control of B virus in 90 to 100%. Reducing cirrhosis, reducing hepatocytoma, reducing, it has been shown, transplantation. And we have now treatment for 80% of cure, and tomorrow 90 and 30% and 100%, with reduction of cirrhosis, hepatocellular, and liver transplantation. And the question of the minister, we have a good minister. You have to demonstrate that the cost of the treatment is lower than the cost of conservation. So the cost effectiveness. And we have even now several publications showing, perhaps selected, indicated that this treatment could be effective, cost effective. And I tried to explain to my minister that he has not to be the minister of a lack of chance for patients.
So we have here a representative from the Ministry of Health. What do you answer?
I am also chair of the board of the National Health Insurance Fund, so that's a harder role in that sense. But for us, it has been extremely important to have public-private partnerships with the pharmaceutical companies, in the sense that we expect solutions from them and risk sharing from the producers of the drugs. One model is managed entry agreements that some companies have offered. Okay, they have a new innovative drug, we will finance that one, but with the savings from another one that is now generic. So playing a little bit with the volumes as a new one is introduced. Especially our legislation used to allow for a new drug to be introduced at any given time in the year. And we would budget, at the beginning of the year, and then new drugs would come through all through the year. And we were faced in front of very difficult decisions. So we actually ended up changing the legislation. Yes, it might. One might think that we've reduced access. We now allow twice a year for new drugs to be financed by the Health Insurance Fund. But that actually helps us, on the one hand, it helps the pharmaceuticals companies plan a little better, and of when their introduction is going to be, and it helps us to actually ensure that what we've committed to reaches the patients. So I think as a government, we look up to the pharmaceutical companies to offer solutions to us. And not only in the moment of financial crisis, in all times, managed entry, and we've always been looking through price volume agreements, clawbacks, etc. And they're very difficult mechanisms to actually implement because of the way taxes are being reimbursed and brought back, but we look for partnerships.
So thank you very much. Good times look in front of us. We have now the break. I have to thank all the speakers, the panelists, and we talked about prevention. Drinking coffee is prevention. Drinking coffee is good for your liver, and keep in mind the good effects of coffee are dose dependent, so the more the better. We will be back in 10 minutes. 10 minutes, and thank you very much again, all speakers. Thank you.